Welcome to Fraud Talk, the Association of Certified Fraud Examiners monthly podcast. I'm Cora Bullock, Assistant Editor of Fraud Magazine, and this month I interviewed Rebecca S. Busch, CFE, President and CEO of Medical Business Associates, a healthcare consulting, auditing, and forensic services firm. Rebecca discusses healthcare fraud schemes, enforcement trends and strategies, and the qualities she looks for in her investigative team. The provider and patient aspects of healthcare fraud are well known. What are the lesser-known healthcare frauds?
The other big area in healthcare, and it is a problem, is counterfeit prescription drugs. I mean, you think about that. You got durable medical equipment, and you have that whole arena with equipment and medications, and then you have your traditional white-collar, blue-collar activity in that you have vendors. So you also have issues from the perspective of a third-party administrator, so an insurance company with an employer and so forth. So the level of healthcare fraud is really deep, wide, and vast, and I mention these other areas because we are becoming more well-versed from the provider perspective, but if you really understand the behavior of fraud, which sometimes I like to coin simply as lying, cheating, and stealing and taking something that doesn't belong to you, it's really not defined per se by a type of person or place. It's really an environment where you have the right opportunity to misrepresent and take something that doesn't belong to you. So I think in the context of healthcare, it's really important to understand there's lots of different players and there's lots of different areas in which you can have misrepresentation in healthcare occurring. So those are just a few examples. There's categories, within that, but what I wanted to highlight in response to that question or bring to people's attention is that it's really across the board. And if you think about every type of vendor or support vendor that's involved, it really can manifest itself in a multiple different routes.
How do you keep from feeling overwhelmed when investigating these cases?
When you sit back and you look at the breadth and scope of it, it can be very overwhelming. And one of the lessons learned, and it really is what's driven, one of the books that I've published on this, is really having a defined, focused methodology, and it's behavioral-based. So when I look at a situation or I have clients approach me, because I have situations where someone comes to me and I think, oh, this is the mechanism of theft, or I think this is a problem that's going on, I sit back and I take a fresh perspective and I say to myself, okay, who are all the players? All right, do I have a durable medical equipment company? Do I have a subcontracted vendor? Do I have doctors, insurance companies? Is it Medicare, Medicaid? Is it a multitude of arenas? And then I sit back and I say, okay, what are the standards? That's my second part. And then the third component is identifying what are the rules, damages, consequences. And then the final component is really understanding what I call transparency issues. Mm-hmm. What is it that I don't know? What is it that I know up front that I can't see? So I'll give you a perfect example of a triangle. So I call this example how you can diversify your mischief. And the subject matter was an audit that I was involved with from a drug manufacturer perspective. And the surveillance tapes are listening to this stuff going on, and of course they're concerned, and what they're reviewing is the distribution of medications, prescription drugs that are either counterfeit or diverted, meaning that they may have taken leftovers that weren't used at a nursing home and then reselling them. So you're diverting medications, and you can't do that. And so this triangle that has evolved is this. You have a group of ethically challenged doctors. You have ethically challenged patients that have been trained. They've been trained, and they're stealing from a multitude of people at the same time. So they're using these patients to get prescriptions that they don't need so they can then resell them on the streets. Then they're having some of these patients, of whom some of them are homeless, by auto insurance and having them get into car accidents being treated by the same provider. So now they're stealing from Medicare, Medicaid, because they get them on Medicare, Medicaid. Then they get them in a car accident, and they use the same people to steal from property and casualty. So property and casualty doesn't talk to Medicare, Medicaid. And then some of them, they were able to get individual group health insurance policies, so now they're bringing in the private group health players into this. And they have this triangle, what I call, they've diversified, which actually brings up one of our biggest vulnerabilities in the market, and that is managing data. I mean, we have enough issues managing data under Medicaid and Medicare and private insurance companies, but we don't have a decent network of data exchange of how patients' information is being used in one market and then literally being transferred to another payer market, issues with people crossing state lines and starting up their practice or their scheme in another state. So it's really a quagmire when you break it down, all the different layers of opportunity. So when someone sits back and say, wow, the amount of healthcare fraud is going up, the answer is yes. Why? Well, because one, even though we are in a crisis and we have access issues, there's just a ton of money, there's a ton of layers, and that unfortunately presents a ton of opportunities for people to create false transactions to get access ultimately at that check. So that's really our biggest headache. Mm-hmm. And I guess I'm so passionate about this subject because it's not just stealing. When you have, one of the cases that I worked on was a rent-a-patient scheme that was very popular 7 to 8 years ago, and basically they would induce employees of employers, they'd pay them money to go have stuff that they don't need. And some of these were very invasive surgeries. So if you think about it, you have patients coming into a clinical setting, they're putting them under anesthesia, they're doing an incision. Healthcare is such a personal, intimate experience that you have people who are taking advantage of individuals. And it's just, to me, it's mind-boggling that you could do that directly with the person. So you hurt them health-wise. The worst consequence, of course, is death. Then you have disability. Then you have the final kicker of the financial loss. So I think that's one of the things, at least the nursing side of my hat when it comes on, is we're really hurting people physically and emotionally. And that's the part, for me, that's devastating.
It's not just Medicaid and Medicare that are vulnerable, correct?
Employers are actually very vulnerable. Their health plan is very vulnerable, just equally, if not worse, I think, or more vulnerable than Medicare and Medicaid. We haven't really hit the breadth and scope of how much employers get stolen from. You basically have $1 million credit line. So out of all the cards in your wallet right now, there's very few people that walk around with a Visa and a MasterCard with $1 million credit line on it, but the most valuable one to a perpetrator is your insurance card. That's the most valuable piece in your wallet, which after I have these patient advocacy, workshops with individuals and employees, the first thing you need to do when your wallet is stolen is not just only report and cancel your credit cards, but make sure that your insurance coverage, that they're notified that your card is gone. So they can prevent someone from using your medical identity to get into any kind of health care provider and initiate services, accumulate false medical information that has nothing to do with you, and then use up dollars that are intended for your use and that of your family, whoever else is on your benefit plan.
What is the percentage of fraud cases in healthcare compared to other industries?
If you look at the pending cases under healthcare basically, as for the the prior year, basically represent about 27% of the cases pending.
How is the new Patient Protection and Affordable Care Act affecting Medicare and Medicaid fraud?
The Affordable Care Act, for example, there's one little provision in there that's slowing down the ambulatory surgical activities. So there's a lot of services that are being done in these ambulatory surgical centers that really are not appropriate. They should be done on an inpatient basis. So the market is moving so fast that one of the controls that the Affordable Care Act is trying to put into place is slowing down the process to make sure that people are qualified, that they do have appropriate surgical equipment, that they do have licensed providers, that one doctor can't be put on the claim representing the services of 5 people, that you actually have to have an individual identifier. They call it an MPI, like a Social Security number, but it's like a National Provider Index number, so you can be identified on the claim form. So there are some controls that they're putting into place that's coming in. The other one I will tell you that will be interesting for me as I sit back being in this field is there are provisions where if you're a Medicare or Medicaid provider that they can come in and do random site visits unannounced. So that's a little bit, different and being, ready and prepared for that if you're a provider. If you're a legitimate provider, okay, I think they're accustomed to that because the Joint Commission has done that in the past. If you're an illicit provider and you're just setting up shop, I think it's these entities that this will be a fresh surprise because there's now a law or provision that allows that introduction. The other thing that I think is really interesting under the Affordable Care Act is they're amending one of the anti-kickback statutes, and they're eliminating the requirement for actual knowledge or specific intent, okay, to commit. And so this is something for fraud examiners to keep in mind when you're delving into the healthcare arena. Some of the structures or processes that you would normally see in other industries, there's some caveats I think that are important to understand. But the defendant, for example, they still have to knowingly and willfully offer to pay remuneration to induce the prohibited referral. So there's still some component of that. And so that's one of the other things that is interesting in terms of what it is that they're doing under the Affordable Care Act. They also changed the relator component a little bit, in that there's some components in which, usually the relator is firsthand. It's firsthand knowledge, is original source is one of the areas. But and then once it's publicly disclosed, that prevents anyone else from coming forward. But it's interesting, there's some discretion that I'm still trying to seek a better understanding of myself, and that is if they have knowledge, even though, it's the original source component, if you have knowledge that is independent and material and adds to the publicly disclosed allegation or transaction, they can still come forward. So they've softened it a little bit, and by appearances it looks like if you have something that would enhance something, that they're still considering looking at that from the relator route, which I think is an area to definitely watch out for and see how that's interpreted and applied, because it's new, right? So you have these new rules, and it'll be interesting to see how the market reacts and how they're actually executed. But that's another area. So for individuals who work with relator, reading that section of the Affordable Care Act, I think is really an important area that you should have on your resource list.
What are some good practical tools to detect healthcare fraud?
So there's simple tests that we can run to look for signs of altered or fabricated records. So on some of the cases that I've worked on in the last year or two where they're high volume, I am looking for the upcoding that we all know about or misrepresentation or so forth. But the other thing that I'm really focusing in on is the language, what they're writing from one patient to the next. That is where they make a lot of mistakes.
If the language dramatically changes, or what exactly do you mean by that?
That's a good question. They repeat themselves over and over and over. If you have to sit down, let's say you sat down right now and you're a nurse and you're going to make up a history of present illness. You're going to go through and you're going to interview a patient and you're going to make up their history. Now, if you've never met the patient, if you're basically lying, it's hard to come up with 100 different stories. That's what I mean by studying language, but it's going to be an aggregate.
Are there any other avenues that could help reduce healthcare fraud?
I think the one area that we're definitely failing on is educating the consumer. They're the front line. They're the one that's walking in the door. They're the ones that ultimately we need to protect and to learn to ask the right questions. So on the consumer side, there's two things, and I view everybody as a consumer: fraud examiners, investigators, patients, from all walks of life. In healthcare, we communicate a what and why every time we do something to somebody. And the what is called a procedure code. The why is a diagnosis code. Mm-hmm. Every patient should never walk out of their doctor's office without asking, what procedure code are you charging me for today? What diagnosis code? Because I want to know what you're putting in my database. And so, like procedure codes for office visits, no one really understands that they're all time charges. It doesn't matter if you're seeing a cardiologist, an OB-GYN, neurologist, or whatever. They're evaluation management codes, and they're all driven on time, all of them. So those two simple things, if we put that information into the hands of the consumer and they start asking questions, I think we could tackle easily 10 to 20%.
What specific experience and skills do you look for in your examination team?
You need to have people that are good at technology and data mining and data analytics. You need to have people who have a foundation in understanding a clinical setting. So that's going to include healthcare professionals. Mm-hmm. And the reason why I highlight team is because I think it's really difficult to find one person who knows everything. So it's really more important, do you have the base foundation skill set to understand who you even need? So if you're dealing with a doctor and it's an oncology clinic, you better have a resource on your team that understands oncology and the latest drugs and how they're used. You need to have your traditional, what I call internal audit skills in terms of quality controls. And without question, you need to have your foundation investigative skills that is taught and sponsored by ACFE. So there's a foundation on how to conduct a fraud examination. So it's that skill set. So it's really a blending of skills and then subject matter expertise.
It's staggering the schemes that healthcare fraudsters use to bilk providers and customers out of their money and good health. We hope you found this podcast enlightening. Thank you for listening to Fraud Talk.